So we're dealing with hypertension. And I'm going to keep moving forward. So we're going to have an introduction. We're going to review pathophysiology, hypertension and hypertension emergencies. So we're going to talk about those. We're going to talk about medications. So we are going to be going over a few different medications and talk about what they're doing, signs and symptoms, and how we're going to manage this. So my favorite slide, as always, how it affects and everything like that. So good numbers to know for some time, not for me necessarily, but some people this would be numbers to know for. I don't know when. As far as our system, everyone remember this from anatomy? Okay, because this is going to be a huge factor. Where is our blood pressure determined from? Kidneys is a main factor for what we think about, right? But there's also other places that affect it as well too, right? So we got to think about all the systems that affect blood pressure. So we can determine out how we're going to treat it. We have to determine out where our problem's coming from. But kidneys is usually one of the main areas we start. So, but those other areas we talked about. So what else is there? Well, we got the liver, we got the lungs, and what controls our body? Brain. So our brain and our regulation down there, we talked about, and I talked about how we regulate everything is going to be a big part. So we have to think about where they're coming from. So let's go back to renin, angiotensin, aldosterone system. You guys love this, don't you? Okay. If you love it, fantastic. So who wants to tell us a little bit about this system? It's kind of right there in front of us, right? A little bit. So knowing this system and how this works is going to be a huge aspect of how we increase our blood pressure and decrease our blood pressure, right? So we're going to talk about this system again, what it does, how do we get our blood pressure going up, what do we get when we're dealing with renin, when we're dealing with angiotensin, when we're dealing with especially trying to get that process coming in. So angiotensin 1 is transported to the lungs, where what acts to convert it to angiotensin 2? Oh, ACE, okay. So what medications do we know that have to deal with ACE? ACE inhibitors. Okay, so where do you think they're going to work? In the lungs. They're going to work on angiotensin converting enzyme to decrease that ability to help decrease our blood pressure. So now we can think about where in the body it's going to work. And if we talk about ACE inhibitors, what does it do? Blood pressure. We know where it's going to work. We know where it's coming into. That's why it's important to have a good background of all this stuff on the anatomy so you know what those medications are going to do. So that's going to go through. And then aldosterone. What does aldosterone do? Nice thing is it's all written up here too, right? What's that? How does it work with ADH?
It tells the kidneys to hold on to water. So
fantastic. Okay. So we're going to think about how that body works. So here's basically our system where our arteries are going to basically have with our baroreceptors that it acts on our brain. So our brain is going to be responsive to our baroreceptors and how it works too. We got to get vasoconstriction to increase our blood pressure. Sodium and water retention are also going to increase that. So where does it act? So this is a good system of how aldosterone acts, how angiotensin acts, and what we can do to break these systems down or reverse these if we want to decrease blood pressure, and what happens when we're trying to increase blood pressure. So, but I talked about the last aspect. What also manages this besides our lungs, besides our kidneys, besides our liver? Oh, it's the brain. So the brain is going to be our main control. And it's going to basically kind of look at our autoregulation. And the big way it works on is acting on the baroreceptors there too. And it's going to be checking to where we're doing with blood pressure on MAP. And how do we determine MAP? Okay. So part of that is up there. Not all of it is, but we'll see that again. So again, an important thing. So you're also going to find as we deal with AHA, they're going to go not so much on blood pressure as they're going to start using MAP numbers. So it's going to be important to realize these. For anyone who's got a life pack, does it give you your MAP?
Yes.
Fantastic. I know the Zols do too as well. So those are going to be things that we're going to be monitoring from that as well. So you might see some change of how we're monitoring besides just doing that. But when we're dealing with hypertension, what's basically our most important aspect that we're dealing with as far as the pressure, systolic or diastolic? Systolic, because we take 2/3 of the cycles in our systolic phase. So we want to work on both, but that's how we figure out MAP, right? 2 times diastolics.
I thought our cycle is spent 2/3 of the time in diastolic.
In release from there, but we also have our systolic that's basically going to be a huge portion. So our systolic pressure is where we're going to get our most effective change to decrease our MAP. But you know, you're right. I did say that. Yes, 2/3 of the time is spent in diastolic portion of it, but our systolic pressure is going to be our most important aspect that we want to change as far as dealing with our MAP pressures. Fair enough? Okay. So eventually we get chronic hypertension. We get this over long periods of time. We aren't able to control this. They aren't controlled either by medication or this. We're going to get damage to the arteries themselves. Think about that stress and the pressure it's getting over a period of time. It weakens that. It takes the elasticity out of that area. It's going to damage the small ones, the arterioles first. The heart's pumping against that. Because we're pumping against higher pressures and we're having that, we're going to get hypertrophy, or basically what's that going to be turning into? Increased muscle mass of the heart, which is going to lead us to congestive heart failure. Kind of fits into there too. Our kidneys are going to be getting more pressure on that, trying to control this. So hypertension can also put more pressure on that, trying to lead that can lead us into kidney failure. So a lot of things, if these are uncontrolled, can lead to, and that's why hypertension is becoming such a serious issue to make sure we maintain it. MIs can be associated with this. CVAs associated with hypertension. AAAs. Central nervous system breaking down and getting lost in the blood-brain barrier. So all these different areas from chronic hypertension can be developed. These are going to be another changes too with the new AHA guidelines coming out of where they're considering what's considered a stage of hypertension. So our normal blood pressure, 120/80. That's kind of where we look at. As we start developing in what they call their pre-hypertension into the 120 to 140 ranges, when we get over 140 to 159, anything above that area, that's where they're considered hypertension. So right now they're considering stage 1 hypertension, that 140 to 159, stage 2, 160, and stage 3 is going to be basically the 179, 180 above, plus our diastolic increase. I don't know specifically on the numbers. Gary has this down and I haven't looked on it, but I believe they've changed those numbers to stage 1 being less than 140 now too.
If I remember right, it was 130.
Was it 130? Okay.
The article that I read on it too was kind of stating, I don't know, I guess it leaned more towards the fact that they had lowered the stage 1 hypertension to 130 so that you could get a quicker jump start on correcting it.
I think you're right. So I know they've lowered the numbers and these are not the new numbers there, but they're changing that because of the issues that we're getting because of hypertension, the amount of strokes, the other amount of complications. So you're absolutely right. It's trying to get people treated much faster.
We need to know that these numbers.
No. I would tend to know. I'd know a stage 2 and a stage 3, but again, those numbers are going to change. So no, I'm not going to hold you to the numbers. Yep. I won't do that to you. So, because like I said, those numbers are changing now anyway. So, fair enough with this. Not much to describe on to there going through, but we'll know the areas are coming in. So basically, clinical presentation and management. Hypertension, generally in most cases, and especially with our lowered numbers, they're usually asymptomatic. They usually don't have problems with it. People manage around with a high blood pressure a long time. A lot of people don't find out, so they go in for a checkup or some other instant comes out that they even have it. Hypertensive urgency, basically this is over long periods of time where they're starting to get issues with this. They can have end organ disease, and a hypertensive emergency is you are definitely getting end organ damage associated with this area. Their BP needs to be lowered. It's got to be emergently. Can we lower it?
Yeah.
How?
Advertising and nitro.
Fantastic. So we have to be thinking of the minimal things we can do. But this is going to be something on a hypertensive. We're going to do whatever we can to lower it on a quick basis. It's going to see something in the hospital. This patient's going to have to be seen over a long period of time. If these patients are not managed, and that's why too, whenever we're out there seeing patients in general getting blood pressures, and you come across someone who's beating for something else, is it a stressful situation that their blood pressure is 160 over 90, or is they at a normal basis? So I always give things with a grain of salt on that. My wife has white coat syndrome. If you aren't familiar with white coat syndrome, every time she goes into the doctor's office, her blood pressure is through the roof. And then I take it at home, and it's back down to normal. So pops in the doctor's office, immediately goes up. So stressful environments are going to throw people up. So I always say with a grain of salt, is this a stressful environment for this patient? And ask the patient, how is your blood pressure normally run? Do they always run high when they see physicians? Because people have white coat syndrome that's out there. We don't really call it white coat as much because doctors don't really wear white coats like it used to be, but that's where the term came from. Yeah.
You're a doctor?
Yes, which means she doesn't listen to a thing I have to say. So basically, as you guys will find as paramedics, you tell your family members, here's what you need to do, and they won't listen to you. But some random person will tell them that same thing, and they'll go, oh, yeah, I've heard it from this. And it's like, yes, so. Yeah, so no, it doesn't work that way. You can ask just about any physician out there, and most families don't see you as that. My friends don't see me as that. They don't listen to you in most cases. It's funny.
You wear a white coat. You're a doctor. But
What's that?
You wear the white coat?
I wore the white coat, and it doesn't. She knows how stupid I am, so she has no respect for me. So it's just. So those are basically things that we're going to be looking at. But those are areas that we do want you to be looking at your patients, especially if they're high blood pressure, saying, yeah, you need to follow up with your doc. You need to be checking on this because those can be causing problems. So here is our MAP equation. I'm going to state it up there. Gary loves to pop things like this on the test. This is going to be a moving towards those areas. Yes, we have automated blood pressures coming out, but some cases our systems do not work and you're going to be using manuals. So I do want you to know basically how to figure those out as well. Yes, the diastolic counts twice as much on these systems, 2 times the diastolic plus the systolic. Clinical treatments on this, diet, exercise, and reduction of stress is always the main area we want to go. Who wants to be on meds? I sure don't. We always want to look for those aspects first, although we all want that quick pill. I'm still looking for that fat pill to get, just to be done, so I just automatically exercises for me.
This is like the opposite medical.
Right? So we're going to see out there. So what are the medication regimens that are out there? Adrenergic receptor agonists, ACE inhibitors, diuretics, angiotensin receptor blockers, angiotensin 2 agonists, aldosterone agonists, so calcium channel blockers. These are all the different things we're going to do. So anyone with hypertension could be on a list of these different medications. That's why another thing we did recently, the last class and this class that we've had that we're actually adding all these medications into your list because you're going to see patients on lots of these different areas. What are they taking it for? What can they be on calcium channel blockers for more than hypertension? Absolutely. What are they on ACE inhibitors for? Well, now we're going to know. MAO-I inhibitors can be going through. All different things there. How does that work? So we're going to be talking about those different things. Adrenergic receptor agonists, these are your lulls. So a lot of medications are basically, not always, but a lot of them are done into groups. So our lulls we talked about are our beta blockers. So how do they work? Well, obviously, it can kind of talk to you through here of where it's working because it's going against the adrenergic receptors, reduction in heart rate, negative chronotropic, contractile forces. So how does this affect our output, our cardiac output? Decreases stroke volume, decreases heart rate. So that's basically how it's going to affect. So what are some examples of these? So now when I ask you, what are some examples of beta blockers? These are our lulls: atenolol, metoprolol, labetalol, propranolol, esmolol, lalin. I can't say this. I'm not good at all these. You guys can see these. So these are different things out there. So I want you to be going examples of this. The hard part is especially with our populations, we're going with tons of generics too. So not only do you have to know trade names, you need to know generic names, and you need to know all these changes out there. The more you can get familiar with it, the better you're going to be at identifying what they're on and seeing what other things could potentially be going on with those, especially if we OD in other aspects. ACE inhibitors. These are our prills. Again, these are generalities. Lisinopril, captopril, enalapril, nalopril. Fantastic. I need help sometimes here. And then our different type of diuretics that we're going to see out there. Our mides for our loop, furosemide, torosumide, thiazide. So different things are out there as far as diuretics. So I want you guys to get used to seeing more of these, and that's why we're going to start seeing pill bottles more and more that are out there in each of these areas. I'm still not putting a lot out there in these early stages of summative scenarios because you guys aren't there with everything we've taught yet. But I want you to start throwing their introduction. You guys start getting used to seeing them. I bet you Gary does someplace in the list of things. If I can find it, I'll let you know. Calcium channel blockers. These are our pines. Again, generalities, how they're going to work and come down to decrease nose. Amlodipine, nifedipine, verapamil, diltiazem are not necessarily in the pines area of how they're spelled there, but these are big things I want you guys to get used to. These are common medications you're going to see out there often. Clonidine, basically treating through the alpha-2 receptors. So this is where I want you to be able to know when we go back to the system of how the kidneys work and where they go. This is where the medications work and how they affect. Other areas that we're doing as far as our vasodilators that are out there for us, nitroglycerin is what we're going to be carrying, and that's one of the few things when we talk about what can we do in hypertensive emergencies. This is going to be one of the aspects. But in the hospital, these are going to be other type of emergency hypertensive they're going to be able to treat them with that we don't carry. And our signs and symptoms that we're going to see, well, big things on this, we're going to have a history of it. Headache is going to be a prominent aspect. Other visual disturbances that we can see with this, nausea and vomiting, restlessness, strokes or TIA symptoms, acute onset, brain bleeds, head trauma, all these can definitely come associated with hypertension and causes, and it has a lot of effects on the body. Big things we're going to be management-wise is supportive care and based on what's needed, right? We're going to be doing continual blood pressure checks on there, making sure we're on the right side. We're going to check it from side to side too. We're going to do different aspects. We're going to be monitoring both serial 3 leads and serial 12 leads, making sure that there's no other changes on there. What can we do to get their blood pressure dropped? Well, we're going to have to go by what our protocols, what we can do on there. And we're going to get this patient to definitive care as quickly as possible. Those are going to be our big goals. Questions or concerns? I know it's a quick rundown of hypertension. We'll get a list on that, but just make sure that you have copies of this or go back and, bless you, review these slides. I want you to know what those medications, some of those medications names pop up. Maybe not so much on Monday, but they're going to pop up again some Monday. Sound good? Questions or concerns? I know this was fairly quick. All right. Well, let's take off. Try and be back here ready to go at 12:30 with your bags.